Good afternoon, ladies and gentlemen. My name is Dagmar Reitenbach and I'm the head of the Global Health team in the German Ministry of Health. I'm honored to welcome you to this session of the policy track on behalf of our ministry. The policy track is a new event format at the World Health Summit, which was initiated by our ministry. The objective of this policy track is to bring current debates from international governing bodies and fora, for example, in Geneva, to Berlin, and to discuss these topics with a wide range of actors within the global health community here in Berlin. Our aim is to gain new insights on matters relevant to policymaking and to use the expertise present at the World Health Summit. We believe that good policymaking relies on listening and understanding. By that, we hope to champion informed positioning and decision-making. We want to feed the findings of our discussions here today and the enriched Berlin perspectives into international processes. The policy track will be characterized by candid, critical, and in-depth discussions. There will be no keynote presentation, and we want to focus on dialogue and interaction. We want to hear your views, suggestions, and concerns. The raising of controversial topics and juxtaposing perspectives is welcomed. Thus, be as frank as possible. I also look forward to our audience's views on this session's topic. We appreciate your participation in the session via our online participation tools. By that, we hope to provide a compelling and engaging session to our panel and audience alike. Now, let me please welcome you to our session, Global Health Governance Post-COVID-19, the SDG 3 Global Action Plan as key vehicle for synergies. I believe that everyone in this room and those following our session online is aware that currently we are not on track in achieving the SDG 3. The COVID pandemic has exposed weaknesses in health systems worldwide and set back progress towards the SDG 3 even further. The Global Action Plan for Healthy Lives and Well-being for All was launched 2 years ago to accelerate progress on the SDG 3. The Global Action Plan was initiated by Germany together with Ghana and Norway, and I'm very pleased that our Norwegian colleague is with us here today. This Global Action Plan was initiated with the objective to improve coordination among the agencies and to tackle fragmentation in the global health architecture. Thus, it was considered a pioneering initiative as it brings together 12 international agencies with mandates in global health. Today, with the joining of the International Labour Organization, the Global Action Plan unites 13 agencies. Germany has always been a firm supporter of a robust global health architecture with WHO in the lead. We are convinced that for a durable and resilient recovery after the COVID pandemic, the SDG 3 Action Plan is more important than ever. Ladies and gentlemen, today we will discuss how collaboration as part of the SDG 3 Global Action Plan can act as a key vehicle for resilient recovery. Also, we will discuss how we can use the learnings from the second progress report of the SDG 3 gap to accelerate a much needed strengthened global health architecture. And now I'm honored to introduce our chair, Professor Suri Moon. Suri Moon is the Professor of Practice and Co-Director at the Global Health Center of the Graduate Institute of International and Development Studies in Geneva. She is also the Study Director of the Independent Panel on the Global Response to Ebola, an initiative of Harvard and the London School of Hygiene and Tropical Medicine. Moreover, she is also research director and co-chair of the Forum on Global Governance for Health at the Harvard Global Health Institute. Prior to joining Harvard, she worked for Doctors Without Borders International Campaign for Access to Essential Medicine. Suri Moon is one of the leading and most often sought out experts in global health governance. She has also consulted for many non-governmental organizations, think tanks, and intergovernmental organizations on global governance and access to medicine issues. Her work has been published in major journals such as The Lancet, the New England Journal of Medicine, and many more. This is only a small excerpt of her many achievements and her immense contribution to global health. Suri Moon, we are honored to have you here today. Over to you.
Thank you so much, Dr. Reitenbach, for the warm introduction. And I want to thank the organizers for the invitation to be here and to serve as your chair. It's a tremendous honor for me. And I think, as with many of us, it's the first time that I have traveled for work since before the pandemic. So really, really wonderful to see so many colleagues in person here on the panel and in the audience, and hopefully also online. Really, really looking forward to engaging with all of you in what we do hope will be a very frank and open discussion on topics that are sometimes controversial, but really I cannot imagine a more important topic to be engaging in right now. So I think Dr. Reitenbach has already given us a fabulous introduction to the topic of the panel overall. And because we have limited time, I'm going to actually dive right in. I will introduce each of our panel members, and then we'll dive right into the topic for the day by looking indeed at what is SDG 3 GAP, what has it done, and what conclusions can we draw regarding global health governance for the future. So we have a really fantastic group of experts here. First, we have Dr. Katrina Blume, who is the Chef de Cabinet, Chief of Staff of the World Health Organization. Prior to this, she was the Chief Executive Officer of FIND, Foundation for Innovative New Diagnostics. She's a world-renowned expert on diagnostics and on tuberculosis. And I think we're really looking forward to hearing your thoughts from the perspective of WHO. Next, we have Dr. Bjørn Inge Larsen, who is currently the Special Representative on Global Health for the Norwegian Ministry of Health and Care Services, formerly the Director General of the Norwegian Directorate on Health, and also a Norway's representative to the WHO Executive Board earlier in his career. Again, a very, very well-qualified expert on a number of the topics that we'll be speaking about today, and of course, representing the country that was one of the co-initiators of the SDG 3 GAP. Last but not least, we have Ms. Priti Patnaik, whom many of you will know by name from having read her Geneva Health Files, she is the founding editor of Geneva Health Files, which has very quickly established itself as one of the go-to sources, I would say, for anybody interested in following what is going on in Geneva in policymaking. She looks at these questions through the lens of power and politics, often going very much behind the scenes and drawing on her 20 years of experience as a reporter to bring the news to us very quickly, oftentimes in an in-depth analytical format that I know is of huge value to many of us in the global health community. So thanks very much to all three of you for joining us. Before diving into the content, I just wanted to let all of you know how you can participate. So we'll have an initial about 45 minutes of exchange among the panel members. And while we're doing that, you're invited to type in questions using the Slido app. I think those of you who have been participating in the summit should already be familiar with the Slido app. You can see here, yes, indeed, you can go to slido.com and the number is here on the screen. You type in 855-543 and the most popular questions will bubble up to the top. You can put in your questions at any time or comments starting now, I believe. We also have a polling question that will open very shortly if it hasn't yet. And about midway through our conversation, we'll put the results of the poll up on the screen. We'll have a second polling question that we'll also ask for your input on. We'll look at that a little bit later in the session. So after this initial 45 minutes with digital and in-person interaction, we will turn first to the audience in the room to share with us your responses, your reactions, your comments and questions for our panel members, and then we'll also turn to our online audience for the same before wrapping up. So without further ado, let me actually turn first to Dr. Bjørn Larsen and ask you, why did Norway join Germany and Ghana in initiating the Global Action Plan? And what is it for many of us who may not actually be so familiar with, in fact, what this initiative is?
Well, thanks a lot. So Norway is a small country, but with ambitions to be active on international help. We are spending around 1% of the GDP as ODA. And that makes us, as a high-income country, that makes us a donor with some funding. And going back to 2018, 3 years into the SDGs and the work on universal health coverage, we looked over this fragmented landscape of entities that is working on health and thought, well, probably we will get better investment or better results from the investment if we ask them to join forces. So that is why the head of states of Germany and Ghana and Norway wrote the DG of the World Health Organization and asked him to develop this action plan on how to work better together to reach the goals of the Sustainable Development Goals. And already on that time in 2018, so it's not just about getting more for the money invested. Already at that time, we could see that the global community was lagging behind on reaching the Sustainable Development Goals in health. So there was a need to take some kind of action to accelerate the progress. And then all the signatory agencies worked together and developed this one action plan where they confirmed that they will be working together, both on the country level and on the global level, to better reach the goals that we've all set for 2013. So that's the background for that. And if you just allow me to say that, so now we've been through this pandemic. And of course, a lot of the attention of the global community and for governments has been on dealing with the pandemic. We have been overwhelmed by the challenges of this pandemic. But if you ask, is the goal of coordination between these entities, is that still a valid and good goal for the future work? Yes, I think it is. And if you ask when we set out with the Sustainable Development Goals, are they good? Is universal health coverage, is that a correct answer to the challenges that we even have seen during the pandemic? Yes, I think it is. I think both of those ambitions, working coordinated and working towards universal health coverage, I think are even today the right answers to the challenges that we have seen.
Well, let's explore that topic in more detail. But first, indeed, for many of us, the SDGs and the Global Action Plan have very much faded into the background over the past 18 to 20 months. So we thought we would spend just 5 minutes showing you a video to give you a sense of indeed what is and who is involved very actively in the Global Action Plan. Could we have the video, please?
Unable to access essential health services. We thought, surely we can do better.
The Global Action Plan for Healthy Lives and Wellbeing for All, SDG 3 GAP, aims to improve the collaboration of 13 agencies across the multilateral system to support an equitable and resilient recovery from the pandemic and drive progress towards the health-related SDGs.
Our aim remains stronger collaboration for better health.
The SDG 3 GAP was born at a time as we gained a deeper understanding of our need for it before COVID-19 hit.
We were already lagging, with at least half the world's population still unable to access essential health services. We thought, surely we can do better.
It's 2021, and we are not only further off track in achieving the SDGs, but for the first time, since their adoption in 2015, progress on the goals has been reversed.
We are supporting countries in a world where inequalities are growing and inequities persist.
COVID-19 has exacerbated existing inequalities across all aspects of life for women and girls.
Now, more than ever, as we fight COVID-19 and protect hard-fought gains made in global health, we need massive and cohesive global investments in health.
The accomplishments of the SDG 3 GAP so far are encouraging, but implementation needs to be expanded further.
Country-level implementation has increased to 37 countries, with many prioritizing primary healthcare reforms.
Our work in Primary Healthcare Accelerator supports government and civil society partners to implement national and subnational work plans. This includes working alongside other partners to provide essential supplies, data, digital health solutions, and other innovations, even in fragile and complex environments.
And in Pakistan, coordinated sustainable financing and efforts to boost the primary healthcare system is paving the way to universal health coverage.
In Côte d'Ivoire, we worked with the Ministry of Health and civil society organizations to support a primary health budget increase of 15% every year.
As part of the ACTA Accelerator and with partners, UNITED is leading the work on therapeutics and also access to oxygen in low and middle-income countries. This work is fully complementary to the work of the GAP to increase oxygen supply in countries.
On innovation, WHO and partners help to scale solar-powered oxygen in Somalia.
In countries like Malawi and Nepal, we work with partners like the Health Data Collaborative. That is strengthening data sources so that countries can assess how they're performing against the SDG health targets.
UN Women, together with the UN University's Gender and Health Hub and key gender working group members, have jointly developed a guidance note. The guidance provides very practical actions that decision makers can take to promote gender equality and ensure an equitable uptake of COVID-19 vaccines by leaving no one behind.
It has spurred the development of a new global dashboard for vaccine equity. To give you one example, the dashboard empowers governments, policymakers and other partners with the very best of data and analytics to accelerate universal access to vaccines.
To align across health partnerships, we're integrating work under the Every Woman, Every Child initiative.
We continue to learn and adapt, to look for opportunities to innovate and to work smarter in supporting countries to achieve their health-related targets.
With countries in the lead, our collective efforts under the GAP are already helping deliver concrete results across health systems while building more resilient health financing strategies focusing on equity.
When we collaborate, stronger collaboration, that means better health.
Our goals for the next years are to at least double the number of countries in which we're working, to roll out the monitoring framework to optimize our support to and measure our impact in countries, and to continue to jointly support countries to strengthen primary health care.
Together
for an equitable and resilient recovery.
Thank you very much. Hopefully this gave you more of a gut sense of what GAP is, what it's supposed to be doing. Let's now turn to our panelists to hear a little bit more about taking a look behind the scenes. What have been some of the challenges actually to achieving this increased coordination? We know that WHO was anointed when it was first created in its constitution and mandated to be the directing and coordinating authority on international health matters. But of course, in the 70 years since it was founded, and especially over the last 20 years, the landscape in global health has become increasingly crowded. We have many, many actors that collaborate with WHO, but sometimes also compete with WHO, arguably. Katrina, I'd love to hear from you. What are some of the challenges that you see in getting 12 to 13 international actors to actually work in a coherent way together? And what are the tools that WHO might need that would actually strengthen its capacity to coordinate this broader system?
Thank you. Let me maybe first say that for me, SDG 3 GAP, but also its younger brother or sister, the ACTA Accelerator, are essential and innovative partnership platforms that I think are more needed now than ever before to fight this pandemic, but also to accelerate recovery and address the SDG 3 GAP. As you said, they were set up in response to a very fragmented global health architecture, but also to adapt the way the agencies work in the SDG area, where we need a much more country-led approach, where we need a more holistic and focused approach. So we've heard here about the successes of GAP in countries like Pakistan, Somalia, and South Sudan, but what do we see as the challenges? Björn Inge, I think, has already outlined one of these challenges. GAP was fairly nascent when the pandemic hit. It was started in 2019, and shortly after, all countries and agencies had to focus on the pandemic first. Going forward, we are seeing very shrinking domestic fiscal spaces, less funding available for health, and we're hugely concerned that that will lead to a further drawback with regard to recovery. So that's challenge number one. Challenge number two, from my perspective, is that GAP, SDG 3 GAP, is based on a self-commitment of 13 entities, voluntary self-commitment. But at oftentimes strong collaboration or achieving strong collaboration, which really is a mindset shift, a behavior change, requires strong incentives. And it requires push as well as pull incentives. Push in terms of countries demanding a closer collaboration on the support they get, demanding coordination on the ground. And on the pull side, from member states, donors speaking with one voice in terms of making their expectation for collaboration clear, but then also translating that in funding decisions. And my view is that in terms of accountability, the performance in collaboration needs to be measured and then translate also concretely in funding decisions, basically to have these incentive systems for players to coordinate. When you look very concretely, just for example, at our operation on the ground in Afghanistan, for example, what you see there is many, many actors on the ground, partially a very unhealthy competition for funding, a competition for leadership, clearly leading to suboptimal response overall. And then thirdly, my third challenge that I'd like to outline to you is, in order for WHO to fulfill the expectation of our member states, we basically need two main things: the capacity to do so, notably in countries, and B, the clear, very clear mandate. On the WHO capacity, we're clearly very much more poor than some of our other SDG 3 GAP partners. WHO's funding situation is weak. We are really faced with a debilitating imbalance between what we call assessed contributions, sort of member state fees, versus highly earmarked funding, to WHO. Most of our in-country teams are living on short-term, very short-term contracts. And that oftentimes leads to a situation in country where WHO cannot properly coordinate partners, cannot properly do what we're supposed to do, which is work on norms and standards in country, help translation of global into national policy. So that, I think, you know, the need to get away from only 16% of assessed contributions to 50% has been a major ask from all the independent panels set up to look at the lessons learned from COVID and what we need to change also for better pandemic preparedness. Second, a clearer mandate. You will see when looking back that after every health crisis, new organizations, new institutions have been set up over the last 20 years. There is also a temptation to do so this time after this crisis, and maybe a bigger temptation than ever before. We as WHO do not think that we need more institutions or we need further fragmentation or parallel structures. We believe that what we need is more coherence and better partnership, both at the global level as well as on the ground. That's why we advocate, for example, for a pandemic agreement, a framework agreement, or what we call a treaty, to get us to better coordination, to give us more teeth to basically ensure that countries work with each other and work together towards better health. I think I'll stop here for the moment, but that's sort of my initial response on the high-level challenges.
Thanks very much. Very, very clear points. And if I could make one observation from your comments, it's that WHO may have had the legal mandate, but when I look at the logos on the screen in the video, for example, WHO is not any bigger nor any more central than the other 12 organizations on this question of, is WHO first among equals or not, has not indeed been clarified. So let's delve into that a little bit more. Let me turn to Preeti now, because I think a number of the themes we've already touched on are not new. We've been talking about fragmentation and especially donor coordination for a long time. We've had the International Health Partnership. We had the Paris Declaration on Aid Effectiveness. We've had multiple efforts before. I think as long as development assistance has been in existence, we've had the same debates over and over and over again, actually, about coordination. It gets a bit tiresome. So Preeti, let me turn to you and ask you, what do you think are some of the underlying reasons for this fragmentation or this creation constantly of new initiatives, which may indeed happen again over the next year or two? What are some of the underlying reasons driving that? And therefore, how do we better understand the challenges that we have to try to address if we actually want a more effective global health system?
Thanks, Suri. I think it's first important to acknowledge that fragmentation is a problem. And there's somehow, as an outsider to global health, as a journalist covering these matters, I feel that it's always like a given that, yes, there is fragmentation. We cannot do anything about it. We should not do anything about it. But I think that's a problem, and we have to acknowledge that fragmentation is a problem. And you're right that these debates are not just a few years old; they are decades old. And many will agree that historically, global health governance has been shaped by powerful actors, not just governments, but also other actors, including foundations. You had Rockefeller a couple of decades ago, and then you have the Gates Foundation and so on. So this dynamic and the push towards fragmentation has always existed. It began, with Eurocentrism, in the form of the sanitary conventions, and then that made way for the US and now G20 and so on. So this power dynamic always exists. It's interesting that our colleague from WHO pointed out the pressure on WHO finances and how WHO is poorer compared to other SDG gap partners, as it were. And this is also not by chance. This has been systematic in that sense. And you will know if you're tracking the sustainable financing discussions at WHO that donor countries have provided unearmarked funding to SDG gap partners, such as Guardian Global Fund, but earmarked funding to WHO that constrains policy space. And in turn, these global health actors actually provide earmarked funding to WHO. So that is the situation which I think is striking. So I think that the causes of fragmentation are it seems as if from the outside very much by design. And the ACTA Accelerator was brought up, and there is this kind of a circular logic that is always interesting to witness. A year ago when ACTA Accelerator came into being, the argument was, WHO cannot handle the international response to the pandemic, so we'll have a range of actors to ensure that the response is effective. And now we are talking about institutionalizing the ACTA Accelerator. And the conversation is the ACTA has done a fantastic job, but what did WHO do? Which is interesting because no one can deny the technical and moral leadership of WHO during the pandemic. There are all kinds of approaches that have been thrown up by the pandemic. But I think it will serve us well to see whether mechanisms such as the ACTA Accelerator or the SDG 3 gap, whether this kind of multi-stakeholder approach and at the same time somehow vertical approach is actually relevant for something as cross-cutting as the SDG 3 goals. Because when you're talking about the SDGs, you're talking about the entire global, the landscape of global health, from maternal child mortality to fighting tobacco to fighting NCDs to TRIPS flexibilities. So I'm not sure whether a decision-making mechanism that is diffused across partners would serve us well.
Thanks very much. I think you raised a number of key themes I'd like to delve into further. And I want to turn back to you, Bjørn Inge, because I think this question of fragmentation has, of course, motivated the gap. At the same time, we are potentially on the verge of creating new institutions, such as a Global Health Threats Council, a Global Health Threats Fund. Who knows how many other new entities may be born in the coming years. And Norway, as a country that you described as a small, but I would say very influential player in the global health system, has in fact been, if I remember correctly, a backer of the creation of a number of new initiatives, such as the Global Financing Facility, one of the GAP partners, CEPI, for example. What do you think? Are we likely to see a number of new entities born in the coming years? Will that add to fragmentation? Is this inevitable? And if so, what do you think should be done about it?
Well, first, I think you're absolutely right. Norway has been one of the countries that have been behind some of these funds that have been developed. So you're right. We have been contributing to this fragmentation. I think if you look at it from a donor's perspective, and then I think sometimes it's quite easy to establish something new. It's a smaller organization. It has fewer goals. You can demand it to be quite effective on the narrow attention that it will have. Politically, it will be easier for politicians to say that we have contributed to this. And I think it would really be unfair to demand the same from the World Health Organization. Because going to the World Health Organization, we're going to an organization that we as countries, we ask World Health Organization to see the whole picture and to sort of take a global leading position, and not to be narrow focused to achieve just a few goals, but to achieve the big goals. And maybe it's even unfair to sort of legalize that we give unmarked donations to CEPI or Gavi or the Global Fund, and then earmarked to the WHO, because the attention span of the other organization is not the attention span of the World Health Organization. So if politicians want to have a focus on their specific areas of interest and going to the World Health Organization, it's quite easy to understand why those donations are earmarked. And then I agree with WHO and Katrina. This is not a good situation. We do not want the donors to be the one who tell the World Health Organization what to do. It's a totally different kind of organization. It's an organization owned by all the countries that are member states, and the agenda of the World Health Organization is really decided at the World Health Assembly. It's not decided by the donors, and it shouldn't be. So the question is whether we can strengthen, like Katrina said, whether we can strengthen the World Health Organization financially through increased assessed contribution and legally through a new treaty, which we support as Norway, and live with the landscape of fragmentation. And I think maybe that is the best option that we have, although it may be a difficult task for the World Health Organization to take that lead. But I think that is what we expect or want the World Health Organization to do, to actually take that lead in this fragmented landscape and to pull all the strings so the total results will be okay.
Thanks very much. I want to pause here because I see that a few questions are starting to come in from the audience, so please do continue to pose those. I also wanted to just take a moment to look at where we are with the live poll. Could we see the responses so far to question number 1? Which asks you to rank which are the issues that warrant the most attention out of 8 options. And we have here the top 3: strengthening the coordinating role of the WHO, focusing on health system strengthening instead of vertical programs, and achieving health-related progress aligned with national priorities. Definitely themes that we've been covering and that we should delve into a little bit further. ACTA has come up already. It was mentioned as the little brother or sister of GAP, as potentially something that perhaps intentionally or not reinforced a vertical logic in global health, despite a lot of emphasis in the SDGs to move away from this traditional emphasis on vertical programs. And also, I think what ACTA has raised, if I look at the most recent report that was issued by Dahlberg, that was commissioned as an independent review, one of the big questions that came up was around the role of governments. And I think the role of governments is, of course, very closely linked to the role of WHO as the Intergovernmental Organization for Health. So Preeti, let me turn back to you now, because I know you've been reporting on this, you've been talking to a number of stakeholders, whether from governments or from civil society. How would you describe the role governments have been playing in ACTA? Is it enough? And what does that make you think regarding the possibilities of, in fact, a more coherent, country-centered governance in the global health system looking into the future?
Right. I think we must note that the strategic review that was sort of commissioned to look at lessons learned from ACTA was kind of had a narrow mandate in that sense. So do keep that in mind, that the review was not an audit, but more on lessons learned and so on. So although it sort of had a let's say constrained mandate, it did throw up a couple of interesting findings, as it were. One is, on accountability. I think the review did struggle to say that it is, given the kind of diffuse decision making, accountability has been a problem within the ACTA, precisely because of this kind of voluntary nature and having a range of organizations. Specifically, the absence of a central programmatic sort of goals, and that leads to gaps and risks of incoherence and so on. do keep that in mind. And the second thing on the role of governments, it's quite clear actually, and this is something civil society organizations have been saying since the establishment of ACTA, that it's not inclusive enough and so on and so forth. And not surprisingly, that's what the review found, that it has to be more inclusive and representative of countries from the South and so on and so forth. We do have South Africa and Norway as co-chairs of the Facilitation Council, but the review did find that the representation has not been sufficient. So the problem with a mechanism like the ACTA is the fact that not all WHO member states are at the table, and that's a problem. So if COVAX has failed to deliver, countries tell us that there is no forum where they can go and raise the questions of vaccine equity and what have you. So I think representation of governments in these kinds of initiatives is central. So that's like a glaring gap. And as far as SDGs are concerned, I think we do have a mechanism for voluntary national reviews that's supposed to also take into account feedback from subnational authorities and so on. But I'm not sure whether the monitoring actually feeds back into the central system. It is an additional reporting line for many health systems already sort of burdened by a number of other reporting requirements. So that's something governments will be able to share their experiences, what they think about this. So I guess to answer your question, I think the role of governments has to be central, and it has not been sufficient. And in fact, this should be sort of a midpoint check, a wake-up call to ensure that there's a reboot in the system, and governments are on board, and not just donor countries, but also LMICs and others.
You mentioned countries saying there's no place where all of us, 194 plus countries, might come together to discuss these issues. But of course, that is the World Health Assembly in most years. So let me turn, Katrina, to you and ask, how would you describe WHO's role in ACTA? And are there the two tools that you spoke about, the strengthening of capacity and giving WHO a very clear mandate to coordinate? Do you think that would have changed the role of WHO within ACTA vis-a-vis all of the other partners?
Let me maybe first start by saying I speak here with a dual hat almost still, because before joining WHO 8 months ago, I was one of the ACTA principals. And I do see the value of ACTA, and I feel it was brought together in a rush. We had to respond to this crisis very quickly, and having lived through it on a day-by-day basis, there are elements of ACTA which I wouldn't want to miss in terms of weekly leaders meeting to coordinate, to strategize, meetings to, for example, on the diagnostic side, work with WHO to very rapidly, get to antigen rapid diagnostic tests, to get them policy approved, to get the price down with other partners, and then to get them scaled up in countries. So this seamless partnership at a global level, I feel, has overall brought a lot of value. And I should also say that Dr. Tedros is and remains, has been and remains a major champion of ACTA, continues to participate in every weekly call. So we believe in this partnership model as such. We also don't feel that WHO can do it alone. We need partners. We have weaknesses, and we need to bring others to the table. WHO as a pillar lead was all over the place, right? We had a leading role as WHO in all pillars. And yet I remember already when I was still an ACTA principal on diagnostics, I felt, well, why do we not get more access to countries, to low and middle income countries? Why can we not fully integrate with national strategic plans? And some of it, I feel, was the crisis mode, right? Many countries at the beginning didn't have very clear national strategic plans. And so in the absence of that, the focus of ACTA remained very global. And that's a big difference to SDG 3 GAP, right? SDG 3 GAP was from the design phase set up to drive change in country. But I totally agree that looking at it now and looking at what we need to change, we need a country connector, right? I think the number one gap is we do not, as ACTA partners, integrate with the national strategic plans. We don't have a very clear picture map of where the gaps of each countries are and how each of the players fits in. And I think it's now at that level of granularity we need to go.
Thanks very much. And I think you mentioned earlier this theme of the role of donors, the idea that donors or funders really hold a lot of the strings in some ways. It was something that I think has come up from a number of the interventions already this morning. So let me turn, Bjørn Inge, to you. What is it that you think donors should be doing more of? Indeed, donors don't call all of the shots, but they call a lot of the shots. And what we've heard over and over again is, I'm thinking about the May 2021 SDG 3 GAP progress report. Actually said our progress will be only incremental and not transformational unless boards and donors really revisit the incentives that they are creating for competition, for suboptimal levels of coordination, if we can put it that way. So what is it that donors should be doing more of, whether it's Norway or some of the other countries that you're in dialogue with?
So if you look at the organizations involved in the SDG GAP, the 13, they are actually very different organizations. Some of them are UN organizations. And I think donor countries, the least we can ask for donor countries that are spending money on global health is to finance organizations like the World Health Organization with ground financing. So an increase in assessed contributions. I think that because we are investing in global health as donor countries, and we need to the donor countries then need to see the risk that donors are actually taking the lead in UN organizations that should be democratic member state driven organizations. So the issue of the assessed contribution is both a signal and a symbol and a reality on this. And then coming to the funds and the organizations that have been donor initiated, I think also donor countries need to see that there is a huge risk of fragmentation, and that there is a very clear signal from donors to these organizations that they should work together, and that they should work together and be coordinated by the World Health Organization. So that should also be a donor message in this.
How unified do you think donors are in agreeing with that idea?
I wouldn't guess.
Okay, maybe we can hear from some other country representatives in this discussion. We've been using this language of donors a lot, and it is still a relevant term, absolutely, but perhaps a bit of a dated term. And I would say that one of the whole rationales for the SDGs and moving from the MDG framework to the SDG framework was to move away from vertical, but also this donor recipient kind of logic that has really dominated global health for the last 15, 20 years, to a different kind of logic of cooperation, maybe even of solidarity. And what we've heard a lot about in the COVID-19 pandemic is, of course, the production of global public goods. And I'm wondering, to what extent have we actually moved in the global health field from a logic of donors and recipients to a different kind of logic? So let me turn to Preeti and bring you in and ask, do you think we've moved away from this donor recipient kind of overarching logic or not? What evidence do you see one way or the other?
Absolutely not. We have not moved away from that logic at all. And as you said earlier in the session, I think COVID-19 has legitimized this approach even further. and that's the unfortunate reality. But you know, trying to sound more optimistic now is a lot of the discussions on financing, you know, are really defined by very strict parameters of you know, abilities of countries to pay. Assist contributions are a great idea, and countries should pay up more. But they are also sort of, at least some of the poorest countries reeling under COVID-19, it might be difficult for some of them to pay up more. And there are all kinds of proposals right now on the table, right? Incremental increase in assist contributions and so on and so forth. But I get a sense that WHO member states are sort of resigned to the possibility of moving towards a replenishment model in a way that countries believe that, okay, we will go down the replenishment route, but hopefully we'll be able to have conditions that donors will not be able to constrain us. Although we know that there are indirect ways to influence policy priorities, but one hopes that there will be like a middle ground, that, you know, you're not going to get a whole lot of assist contributions. That's the reality. But there has to be a way out. So maybe, you know, countries will be able to, or there will be mechanisms in place that will ensure that, you know, unearmarked funding to solve this problem, and sort of in a multilateral way.
Yannicka, you want to come in on this?
So just a comment from my side. So I think the pandemic has been quite an experience for a lot of countries. And I think many finance ministries have been struck by the fact that the economic cost of a pandemic is not really related to health costs, not mortality, not disease burden, not health sector cost. The real cost is on the social society, closing down societies, closing down businesses, culture sector, and so on. And I at least in my country, and there's a real debate on the fact that we, as Norway, the costs related to this pandemic, they have been on everything else. And investing in the World Health Organization, investing in CEPI and Gavi and other organizations are actually much more of in investing in our security and our economy than we had thought before. So I think you can argue today that the funds coming into this should actually be much more diverse than it has been earlier. And my understanding is that ministers of preparedness and ministers of health, they have a strong self-interest in working with the finance ministry and investing in this global preparedness.
Let me just take a moment to pause here, because I think what I'd like to do is open up the floor. I see we have a fantastic set of expertise in the audience and some questions coming in. Let's see the response to, actually, let's hold question number 2. We'll come back to that in just a moment. What I'd like to do is come to the audience in just a moment. And just give you some preparation. I'd like to call your attention to some of the questions that are coming in on Slido, in case you would still like to upvote the ones you'd like to hear some responses to. And to give you a couple minutes to think of your questions, I'm going to pose one last one to Katrina, which is coming back again to this theme of donor-recipient logic versus perhaps different kinds of logics. And indeed, when we're talking about the World Health Organization, we don't hear the language, at least perhaps not as much. It's a language of member states. Berninger described it as a democratically governed entity, and even among other UN agencies, many of the UN agencies involved in the Global Action Plan, many of them are not governed in the same way. They're not governed with all member states coming together once or more each year to really say, this is what we want our World Health Organization to do. What do you think it would take to move global health, to truly move global health beyond this donor-recipient logic, which is not to say development aid doesn't matter. I think it absolutely will matter for many years to come. But certainly we've heard a lot of different ways of thinking over the last year. What will it take to actually move the field of global health beyond what has been the organizing logic for the last 20 years?
very simple question. No, but maybe let me start by starting where Björn Inge stopped. So I think, the loss of trillions over, the last 2 years has been a wake-up call for many countries, high-income countries, but also low and middle-income countries. And so I think we do have a window of opportunity to break the status quo and to drive change. However, I see that window of opportunity is rapidly closing, and many of you may have lived through these cycles of panic and neglect when it came to Ebola, when it came to Zika, and in the end, we didn't see any change afterwards. At the moment, what we see especially low-income countries still very much fighting with this pandemic, seeing huge inequity, for example, in terms of vaccine access, but also oxygen access, and feeling that the G20 discussion, for example, on the future pandemic health architecture is still very removed from them, because what they struggle with on a daily basis is that very few of their people on the ground have access to these tools. And if we collectively cannot drive access to these tools for low-income countries, why would any sort of future health architecture that we dream of now make this situation better for them? Just coming off a call with the African Union, for example, in South Africa, we heard loud and clearly that, while in principle they would be for a global threats financing board, a G20 plus global health threats financing board, they will no longer accept this traditional donor approach, and they want a seat at the table. We hear increasingly as WHO that member states, low-income countries, are proud of being a member of WHO, of the fact that every single country of our 194 member states has one voice, and that it's truly universal, truly inclusive as a mechanism, and that you don't have a greater say if you are a donor necessarily in the World Health Assembly than if you're a low-income country. We actually see a lot of willingness of low-income countries to increase assessed contributions. We see less willingness, mostly actually from BRICS countries, right? Because for them, it's really a lot of money, the way the assessed contributions are calculated, right? This is a big increase, especially for the BRICS, but also because we in a way, WHO at the moment is the victim of geopolitics, right? The rift between the US, China, and Russia has almost, never been so big over the last decades. And we see this whenever we come to the negotiation of the global health package we're looking at now. We do see, for example, as WHO, significant value in a new funding mechanism that would bring more funding, additional funding to pandemic preparedness, because we feel that health security has been chronically underfunded over the last decades. But we see that it's, or for example, the G20 plus health threats financing board, we believe that there is value in better coordination of health ministers and finance ministers, in finance ministers finally coming to the table when we discuss health matters. However, what we see is that, the health threats financing board, for example, is basically dead now. Russia and China have put a red line forward. We're likely next week at a G20 leaders meeting not see any change. It's going to be a pretty weak declaration. And I think that shows the skepticism on the one hand of the lower income countries, Brazil, South Africa, that feel that they've really been left behind in this pandemic when it came to access, and that such G20 structures would not truly bring change, and that really want to now see something inclusive, something universal that drives and fosters engagement of all countries. And on the other hand, we see very clear conflicts, animosities, and geopolitical differences in opinion that prevent us from driving change. And I think, frankly, as I sit here today, the biggest risk is probably not more fragmentation, but preservation of status quo. Then just quickly a comment on what you said, Priti. You know, we actually see quite a bit of openness to a replenishment mechanism. And we, as WHO, do see that this could complement an increase in assessed contribution, especially when it comes to areas of topic outside of our base budget. So this is a very active ongoing debate, and I wished we had Björn Kümmel here, who leads the Sustainable Financing Working Group, and and I think would also make the case for this. But I want to bring this up because what makes coordination for WHO today difficult is, among others, also that we are more or less a contractor to the Global Fund. We're in some ways a contractor to Gavi, right? We're a recipient of highly earmarked funding from these entities, and in the same time are supposed to have a coordinating role, work with them and bring all the countries to the table with equal voice for decision making. So we can come to discussing a little bit more what changes we as WHO imagine on the governing side in terms of our governing bodies. And I see, for example, one of the IPPR leads here in the room, right? There's also suggestions being made on strengthening the governance of WHO further.
Thanks very much. And I'm really glad you raised quite explicitly a number of the geopolitical tensions, because when we speak about fragmentation, it's not only new quote unquote global health initiatives that may be created, but of course the entire global system, not just the global health system, but the global system indeed fragmenting with quite different visions of what international cooperation should look like. What is the role of regions versus any kind of global entity? What is the role of clubs? Emerging powers, of course, perhaps wanting a different set of rules from the ones we've had before. And Preeti was mentioning the TRIPS waiver, I think, is a reflection of some of the very, very deep disagreements actually at the global level on these questions. And a loss of trust to an extent that I have never seen before in the ability of the global health system to actually deliver, very much linked to the question of vaccine access. Great note on which to turn to our in-person audience. So what I'd like to do is to open up the floor for any comments, reactions. Please do stand up, introduce yourselves, tell us who you are, make your comment. And if you wouldn't mind, just lower your mask when you're speaking so we can have a good, clear sound. And then you can feel free, of course, to put it back on when you're done. So I see one hand in the back, 2, 3. Let's, yes, we can actually start up here in the front. Let's take a cluster of comments or questions together. Thank you.
My name is Andreas Wolf, working with Medico International and the German Platform for Global Health. I would like to comment and also raise a question of one of the comments of Mr. Larsen, when he said there is this opportunity that now security issues become up and have an opportunity to raise more funding for global health issues. We have followed this ongoing debate about if the security arguments should be so placed centrally into global health, because the danger always is that then also security arguments would come into the play when we think it should be very clearly focused on a human rights-based approach. And so this is a dilemma that I see at the current moment, when you're saying this is the window of opportunity, this is the situation where there might be some change and willingness also to fund global health further. But if this goes along the streams of a health security perspective, then we are rather critical towards it. And I would like to happy to hear some voices from the panel on it. Thank you very much.
Thanks very much. Could you just hand the microphone behind you to, I believe that's Anders Nordström?
Yes, yes, this is Anders Nordström. I'm the Swedish ambassador for global health. And as I think Katarina was saying, I was working with the independent panel now for the last year. A fascinating discussion, and I will not comment about the financing of WHO, but it sounds very interesting. I would love to hear more about that, but not now. Same thing when it comes to international financing or new boards or councils. But I would rather like to say a couple of words about the GAP and the ACTA. I thought that was extremely interesting that you brought up the two. Because while I was away, some of my colleagues made some interviews about the GAP. And basically, the response was very negative. Didn't work, didn't deliver. When we did the interviews about the ACTA with the panel, yes, some concerns, some critique, but big picture, it worked. Delivered. People involved very much appreciative of the way that platform was set up, getting people to focus on a specific result to be delivered. And I think that was part of the problem with GAP. The GAP that was too broad. But there's another problem, and that's what I would like to come to, more thinking about the future, that the GAP 13 partners are basically representing the old world, the MDGs. Today, we are speaking about the global health architecture for pandemic preparedness and response, but the GAP is about SDG 3. That is about ensuring that people can live long and healthy lives, meaning that you need to take a much broader approach to health. How do we get an architecture for that? And right now, when we are in the middle of the pandemic, can we think beyond the virus and the vaccine? And then for me, all of this, when we need to look into the future structure and architecture, we need to think about functions. I think there is a little bit of an unhealthy thinking that WHO can do everything, even if WHO is saying that they can't do everything, but to think about functions. You need a leader, you need a convener, you need a normative and technical, but you need a financer, and that's somebody else. You need somebody that provides, when that is needed, also global procurement. That's, again, somebody else. Just to think about functions and in the sort of perspective that we're now speaking about SDG 3, something different. And the world has changed. This should no longer only be about aid and donors. I mean, health is a global public goods, and now we're living that, but what are the implications then for the future? And my question sort of to you, and you hinted at that you're also, like me, quite frustrated about the political situation right now. There is a lot of proposals on the table. It's not a rocket science to change some of the things that needs to be changed. I mean, if you compare with some of the more big political issues in the world or the economic issues in the world, this is quite simple. So why aren't our politicians just getting the act together and doing this? How can we, so in some way, unblock and getting some of those things done? The financing of WHO, the future of ACTA, scaling up the financing for pandemic preparedness and response for the future. I mean, it's a no-brainer. So why can't we just get the politicians then to agree? Instead, what we see now is then inward fighting on very specific details issues. I'm quite concerned about where we are right now. If this is not the defining moment and the wake-up call for the world, then I don't know what's going to happen. Thank you.
Thanks very much. A lot of challenging questions for our panel. I'll give you 30 seconds to reflect on that while we hear from our last audience member.
Thank you so much. So my name is Mohammed Ibrahim Khan, and I am the liaison officer for IFMSA, the International Federation for Medical Students Association. We connect 141 member organizations from 130 different countries. And it was really a fascinating talk to listen to. But my question is that how are we envisioning the involvement of all stakeholders, especially young medical students who are the future of this governance? And what do you think about that? I would like to hear the notes from the panel. Thank you.
Thanks very much. Let me turn back to the panel. Anyone want to jump in first?
I think I'll address the question on the trend, towards the securitization narrative. That's definitely concerning, but sadly also inevitable. I think a lot of people who work on the field will agree that it's a very difficult moment to take a step back and say that this is not about security, about health security, but the overall health security narrative has been around for decades now. But the problem with this is, and you sort of touched upon it, a lot of people believe that using a securitization approach actually leads to trust deficit. So in the context of this, overwhelming emphasis on securitization, we have these conversations on access to outbreak areas and greater compliance and so on and so forth. But that actually changes the complexion and the nature of the debate and the kind of solutions we are trying to forge. But I guess this is big money. So when you talk about health security, you will be able to raise finances. But the problem is, will it really be for the communities? Will it really be? Will it really serve the purpose? So that's the question.
Thanks. Renanga, you wanted to come in on this?
Yeah. So that was a mix of quite difficult questions. So just let me comment out of two positions. So first, about the health security issue and not the human rights issue. Well, I think it's a fair observation that the global public goods that we need and that have been too weak during this pandemic, that's been a problem for high-income countries and low-income countries. And so far, a lot of the extra financing going to the World Health Organization and other organizations, the earmarked funding and the non-so earmarked funding, that has been coming out of development funds. I don't think it's wrong to say that high-income countries should invest in global public goods, and they should do so in self-interest and in the interest of all other countries. And we need increased funding for that. So doing that in a security perspective, I wouldn't find wrong. I would find that sensible with the experience that we have. And then, Anders, you had a series of good observations. And why can't we just agree? Well, there is something about the geopolitics, which is, of course, very important. I think also many governments haven't really consumed the reflections after the pandemic. I think many countries, including yours and mine, who see ourselves as friends of international health, we have been very inwards looking during the pandemic. We have been surprised by how overwhelmed we have been by this pandemic and struggled to deal with this pandemic internally. We haven't really been able to do that international job good enough as countries. And I think when Katrina say that, we have then established new mechanisms like the ACTA in the middle of this crisis, well, new functions that are established in the middle of crisis, they are quite difficult. It's really difficult to have a success when you do something in that rush. So I think now we have the time to reflect and to create something which is more sustainable. And because I'm quite sure that next time we have a really serious crisis, countries will need to look back at their own population. High-income country governments answer to their population. That will be the reflects the next time as well. And then we need really strong mechanisms that are pre-thought of and good organizations that will ensure that the international perspective of equity and goods is functioning much better than it did at this time.
Do you want to respond?
Yeah. Maybe quickly on the first question on health security, just reminding all of us that for me, global health security is driven by three things: good governance, good financing, and good systems, strong systems. And that as my Director General often says, health security and universal health coverage are two sides of the same coin. And in terms of interventions, in parts need very similar work on the ground and by countries. Notably, one important common factor, and that's also what we've seen in this pandemic, is the strengthening of primary healthcare systems. And this strengthening of primary healthcare systems, for me, is the essence of SDG 3 GAP, and where GAP could really bring a lot of value. And that comes to the focus question you asked, Anders. I do feel that the focus of GAP should be to work with countries on strengthening primary healthcare systems. And that's, I think, a very common interest and topic for all the partners. In terms of why can politicians just not simply agree? I think we've also collectively done a lot to confuse them. We counted, I think, in the meantime, over 450 different recommendations from, various academic institutions, panels, etc. So I do feel there is a lot of confusion out there still, for example, when it comes to the different boards, the new councils that's being proposed, what's really the difference, what's the commonalities. So I think having great clarity on what are the 5 top things that would really make a difference to global health could have helped a lot, especially 3 months ago. And then to the question on bringing all stakeholders to the table, that's definitely an important one and not always easy. As WHO, we have a youth council. We have this year for us is the year of the workforce. So we have a lot of sessions to hear the voices of healthcare workers, of doctors, of nurses. But it's not always, and we've talked a lot about how can we bring the community voices and civil society more to the table. And so you have not responded to this question, but I think, we're open to suggestions on how to do more, and that's certainly important. We would like to actually have your thoughts on this. But, I feel we've set up a lot of mechanisms over the last years to hear of a greater variety of stakeholders.
Thanks very much. I want to turn to our online audience because we have a number of questions that have come in. The one that has received the most votes, and I think you can perhaps put them up on the screen, comes from an anonymous participant who says that in April, The Lancet defined ACTA as, quote, another vertical program that heavily focused on technical solutions, unquote, and reinforces inequalities. Thoughts? And this is, I should highlight, I think this is, we're hearing some quite different views, right? We just heard from Anders Nordstrom that GAP didn't work and ACTA did work. We're hearing from an anonymous participant and 8 of his or her colleagues. It actually was moving us in the wrong direction. So let me pose this question to our panelists. Between ACTA and GAP, what are the lessons for one for the other? Indeed, have we moved backwards towards vertical solutions and a reinforcement of inequalities? And then we have another question coming from our online participant, Boris Azais, and I think there's actually a couple of questions that touched on this theme also coming from Cornelia Albert on this question of stakeholders. So Boris says, why no voices from recipient countries on the panel, referring us to Dr. Chikwe Iyekweazu's intervention at the European Health Forum Gastein a few weeks ago. Cornelia Albert asks about how SDG GAP entities meaningfully engage with communities and civil society. How do GAP members actually try to achieve this? And indeed, I think the question for the members of the panel is not why does the panel look the way it does, but what does this question prompt you to reflect on more broadly about the way global health is governed? So let me turn to you. This is going to be probably your last set of comments. And then what I'll do is try to wrap up before we give the floor back to Dr. Reitenbeek and hear from the last poll. There's an audience poll for which you still have a few minutes to answer the question regarding what you see as the utility of GAP in the future. So I'll give our 3 panelists a chance to reflect on the audience questions. And because this is your last intervention, I want to actually take the moderator's prerogative to foreground one which Anders flagged, which is that in some ways SDG 3 is a much bigger, more difficult goal than ending this pandemic. And yet, if we think about how we've done, what is it with all of the fragmentation, with all the geopolitical tensions, with the risk that, in fact, nothing will change despite the historic nature of this crisis? what is the one thing we need to do if we're actually going to be serious about moving towards SDG 3? Let me start, Katrina, with you.
Hey, I just spoke. Yeah, I would actually, if we could show these questions, I'm not sure I captured all of them fully, but let me maybe start with the question on ACTA versus GAP. So Jeremy Farrar said last year that ACTA could have never been born without the existence of SDG 3 GAP, because that was really sort of, the idea on the table it had starting to work. And so this collaboration model was very much set up in the spirit of SDG 3 GAP, but with a much more shorter term focus and with a much clearer target and focus. I do think that both models have shown successes and have shown failures. For me, as I said, ACTA on a global level, has made very concrete achievements. If we would have been, as ACTA partners, been successful in bringing funding on the sufficient funding in early enough, I feel that the supply vaccine, notably vaccine supply problem we're in right now, would not have existed. That hugely decreased the negotiation power of the ACTA partners. But I think, if it weren't for this vaccine supply issue, I think that it has been a crucial new funding partnership model on multiple fronts. And I think we will still learn a lot of that on that over the next years. GAP, on the other hand, I feel is completely the right set, is founded and set up with completely the right set of ideas behind it. I think as the SDG 3s are really the responsibilities of countries. They're not the responsibility of donors, and they're not the responsibility of international agencies. And so this belief that countries need to lead, countries need to have their strategic plan is the right idea. And that then donors and agencies come in to support countries in realizing their strategic plan, for me, remains the correct idea. Now, SDG 3 GAP has been set up within the existing suboptimal fragmented landscape. It's not been set up, with a vision to completely change this landscape, but also, as Björn Inge said, do we even have the possibility in the short term to drive radical overarching change to this landscape is not likely. That's why I firmly believe that SDG 3 GAP will continue to play a role, but needs to sharpen its focus, needs to be more targeted, and needs the collaboration incentives that I spoke about earlier.
Thanks very much. Gunnar?
So, well, I think if we look at the situation globally today and see how vaccination has been very unevenly spread across countries, it's very hard to give the anonymous question a right that actually we haven't had success in creating a fair level of equity. Just sitting here today, I think the situation is not the way it should be. I'm not sure it's because the ACTA is wrong or the GAP is wrong. I think it's more a picture of what you get when the world is unfair as a start-off, and you have a crisis where countries turn inward and concentrate on their internal problems. And so just coming back to the importance of the dialogues that we are having in the World Health Organization just of today, slow, difficult dialogues with minimal progress and a lot of chance of disagreeing in the end, but still very important dialogues on how to finance the World Health Organization sustainably in the future, and how to improve the legal framework for the global community to work in the next crisis. And I think the mechanisms and systems to improve equity must be in the center of that dialogue. So, and that is one of the reasons why we are in favor of trying to develop a new treaty on this. And it's really to be based on the experience of what we have seen fail during this pandemic.
Thank you very much. Preeti, last but not least.
I think I've spoken a lot about ACTA, but the only limited comment I'll make is that we have to be mindful that, in any interagency collaboration model, there are spheres of influence, and a number of these partners have diverse constituencies. And that's, I think, inherently problematic, not so much perhaps for the SDG 3 gap, but if you look at ACTA, IFPMA is at the table at Act A with diverse motivations as opposed to a national government. So I'm not sure, there are two different directions in which this whole system is working. So that's the word on ACTA. And on the wider, global health governance question post-pandemic, I think Katrina has alluded to it. Health system strengthening is front and center as far as priorities are concerned, and it will have a overriding impact on the progress towards the SDG 3 goals. And the way this has to be done, a lot of people that I speak to say that there has to be, it has to be a multilateral financing facility, probably anchored at WHO, but not controlled by any one government. Where all countries will have access to this financing facility, and it has to be truly multilateral in nature. And countries should not be left out of it because of their inability to pay. This is one of the blue sky ideas, as it were. So that's how one could potentially begin to address health system strengthening in a systematic manner.
Thank you so much. If I could just draw off some of some common themes out of what each of our panelists has mentioned, as well as our audience members, I would say there's maybe three, and one is really about, if we're thinking beyond the logic of aid, of donor recipients, of a different kind of global health governance. What I heard over and over from all three of you was countries and governments, that SDG 3 is a responsibility primarily of governments. GAP or ACTA can try to coordinate international actors, but at the end of the day, this is in the hands of governments, and that this is both governments looking inwards at their own health system, but also governments negotiating with each other. And what I think, Berninga, you described as slow, difficult negotiations. And Katrina, you reminded us earlier about the geopolitical context within which these very slow, difficult discussions are taking place. And yet, if we are to avoid status quo paralysis, and I think we were reminded that would be a terrible failure on the part of all of us, if there was no strengthening of institutions that came out of this crisis, it would be an absolute collective failure on the part of the global health community. If we are to avoid that, we have to engage in that difficult, slow, ongoing discussion. Last but not least, my own conclusion is that fragmentation, both within the global health system and in the global system more broadly, is inevitable, will continue to happen. But what this means is that it's more important than ever that we think very hard about who can coordinate a fragmented world. And one of the big questions that remains unanswered on the table is whether there will be enough agreement among governments and other stakeholders that WHO should be playing that coordinating role. Very much an unanswered question, but one that I think our panelists have reminded us to think very hard about the importance of this. So with that, let me wrap up this part of the program and thank all of you. You've really reached my objective for this panel, which was to help me to think differently about these questions that we're wrestling with every day. And let me give the floor back to, before I do, let me ask for the last live poll to be put up, which is actually asking the opinion of all of you on the role of GAP to enable better collaboration in global health. How central is this? And we have 46% saying 4 out of 5, yes. That's the winner, but quite a spread across 2, 3, and 4. Last but not least, as Dr. Reitenbach mentioned, this new global policy track is an experiment. In a way, it's the first time the World Health Summit has done this. So we do ask all of you to spend 1 minute filling out an evaluation when the event is over. And with that, let me give the floor back to you.
Yeah, thank you very much. Thank you to all panelists, Katharina Böhme, Björn Inge Larsen, Priti Patnaik, and our chair, Suri Moon, for this compelling discussion. Thank you to the audience for your contributions to this session. Speaking for my ministry, I believe that we were able to gain valuable insights on the SDG 3 and the global health architecture, and heard some challenges on this. 2 years into the Global Action Plan, the progress has been encouraging so far, but we can and we have to accelerate that progress, and we have to address the challenges in the global health architecture. Thus, we fully support the objectives of the signing agencies of doubling the number of the participating countries from 37 to 74, and we support the rolling out of the monitoring framework, as we heard before. Today's session provided us with the information needed to further support the important work of the agencies, with WHO in the center as part of the Global Action Plan. Thank you once again. Stay healthy, and see some of you at the opening ceremony. Bye-bye.